Hello everybody, just going to start now. So just so everyone's aware, the normal chair for this meeting, Ruth Milsom, is currently sent their apologies, so we don't actually have an elected chair for this meeting. So what we do have to do now is elect a new chair to hear this meeting. So are there any nominations for the chair of this committee meeting? Yep, and do we have any seconders for that nomination? That's seconded by Mary Lee. Is there anyone else wanting to be nominated? No. So all those in favour of nominating Mick Stowe as chair for this meeting, if you just raise your hand. So that's all in favour. Thank you. So yeah, I declare that Councillor Mick Stowe is appointed chair of this subcommittee. Okay. Great. That's it.
Right, welcome everyone to today's meeting. We've got first item on agenda is welcoming housekeeping, and I'll hand over to Sam. Sam?
Thank you, Chair. So before we start, there are just a few housekeeping arrangements to mention. Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test planned for today. If there is an emergency evacuation, please take instruction from the council staff present. The assembly point is in Tudor Square. The meeting today is open to the public and will be streamed live and for subsequent broadcasts via the council's website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the council's published policy. By entering the meeting room, you are consenting to be filmed and to the possible use of those images and sound recordings for webcasting. Thank you, Chair.
Thank you, Sam. Next item on the agenda is can scrutiny members and scrutiny officers introduce themselves. I'll start, and I'm Councillor Mick Stowe from Barnsley, and I'll move to Councillor Simon Wright, to my right.
Councillor Simon Wright from Vice Chair, Health Scrutiny for Nottinghamshire County Council.
Catherine Harkler, Democratic Services, Nottinghamshire.
Hello, my name is Councillor Eve Keenan. I'm the Chair of Health Scrutiny in Rotherham Borough Council.
And I'm Kerry Grinsell-Clinton. I'm the Governance Advisor that supports the Health Select Commission in Rotherham Council.
Good afternoon, I'm Christine Rothwell and I support the Scrutiny Service at Doncaster City Council. Thank you.
I'm David Knight. I'm again from Doncaster and again on the overview and scrutiny.
Councillor Mary Lee from Sheffield, and I'm a member of the Health Scrutiny Board in Sheffield.
Sam Wolstow, Democratic Services, Sheffield City Council.
I'm Emily Stanbrook-Shaw, Policy and Improvement Officer at Sheffield City Council. I'm Anna Marshall, Scrutiny Officer for Barnsley Council.
Thank you very much for that. Next item on my agenda is apologies for absence. Sam?
Yeah, we've got apologies from Councillor Ruth Milsom from Sheffield and Councillor Mike Robertson from Nottinghamshire.
Thank you for that, Sam. Next item on the agenda is exclusion of the public and press, and there are no items required for exclusion of public and the press. Item 4 is declarations of interest. As any member wish to declare an interest of any of the items on the agenda? No, thank you very much. We'll move on. So the next item is minutes of the meeting held on the 10th of October 2024. I know I were at the meeting. Can they be moved by someone who were there? Moved by Councillor, sorry.
I was at the meeting, so I'll move them.
Thank you very much, Councillor Keenan. I'll second those minutes. Next item is public questions and petitions, and we've got 3 people indicated that they want to ask a question. What I'm going to do on item 6, I will take 2 of those, but the third question, I've had a conversation with Nick Trott, is directly regarding gluten-free, so I'm going to take that question when we get to item 8. So the first question is Doug Wright from Doncaster. Your request is denied for the reason is that this is the appropriate time on the agenda, but what I am going to say, Doug, you could freely stay for the item that you've made reference to, and then after that you can send in questions to the appropriate authorities and you will get a response through that. I'll answer your first part first, and the advice I've received is this is not a public meeting, it's a meeting held in public, so there is a difference. The second point about where meetings are being held, do we respond today or will you respond later? You will receive a response from writing from the organisers of this meeting on why they are held in Sheffield and not the question that you requested. Okay, thank you for that. The next question, I'm informed, is from Nora Everett.
My question is the content of the first item that you're discussing for consideration. It's that the 10-year plan is not a statutory document, and there are existing laws that are relevant to the changes that you're discussing in the commissioning arrangements for health and care services in South Yorkshire. There is a section of the 22 Health and Social Care Act that is very relevant about public involvement in changes and proposals to change commissioning arrangements that might affect services as available when needed, or the range of services that might be available to the public. And I will be taking this up nationally with other organisations, but under that section, it's section 25 and it's subsection 14Z45. It requires public involvement in the proposals, the plans and the decisions taken to change such commissioning arrangements. And I believe that the current pushing through of the 10-year plan to make these arrangements and insist that locally they are implemented without delay, and it is illegal. And I'd like your views on that. Thank you.
Thank you, Maura. Will you respond to that in your presentation? Yeah. Can I just remind people, though, about public questions? And public questions, the criteria is that they normally come 3 days in advance, so that gives officers time. That's in the standing orders. We'll try and make that clear in future, because then it's an opportunity for officers to answer your questions before you arrive. Okay, thank you. We'll now move to item 7, and it's the ICB Organisational Change Update, and presenting officer is Gavin Boyle. So welcome, Gavin, who's the ICB Chief Executive Officer.
Thanks, Chair. Can everybody hear me okay? Yep. So I'm Gavin Boyle, I'm Chief Executive of NHS South Yorkshire, and here today really just to brief you on changes to the organisation that I lead. So there's a little bit of history. There are some slides, but I don't know if you've got them to put up. That's okay. They're not. If you can get them up at some point, that'd be fine. But I'm happy to speak without them. But in essence, I'll tell you a little bit about the changes that have happened, why they're being proposed, and also what our response is to them. So I think the beginning of this really was an announcement made back in March by the Chief Executive of the NHS, or the Transitional Chief Executive of the NHS, Jim Mackey, and I think it was also echoed by the Prime Minister on that day, which related to two principal changes to the NHS architect. One was the move to absorb NHS England into the Department of Health and Social Care over a period of a couple of years. But the second announcement was a change in the focus of integrated care boards, which were established as part of the Health and Care Act 2022, and also the running costs, the funding for those organisations. I think it's really important as well to make a distinction between, this is about how the work of the ICB, what it focuses on, and its operating costs. It's not about the £4 billion worth of NHS services that we commission on behalf of the people of South Yorkshire. It relates to the running costs of the organisation, not the services. But in essence, there were two parts of the announcement. One is a change in role. So I think possibly just to reassure members of the public, what they want the ICB to do is to concentrate solely on strategic commissioning. So a view has been taken that where we add most value is with regard to understanding the health needs of our population, developing commissioning plans, and securing those services from service providers to meet the needs of local people. So in essence, what the change in our role was is to focus solely on that. So at the moment, we've got some responsibilities for oversight of provider organisations, so making sure that the hospitals, mental health trusts, etc., are delivering services appropriately. We've also got some responsibilities to kind of convene and lead the system. So we bring colleagues together, we agree priorities, we do work together, but we have a sort of facilitating role. But I think the direction was to not do those things, but to focus solely on the commissioning of NHS services. And in the 10-year health plan that was published recently, there is actually quite a focus on the role of the ICB as Strategic Commissioner to deliver the aims of the 10-year health plan. So we will look very, very different. I think the other part of the announcement, so it's a change in role, but also a change in the resources available. And what the government were asking all of the ICBs to do nationally, reflecting the fact that their role was narrower, to reduce their costs by about 50%. And I'll explain just how that was calculated here for South Yorkshire. But in essence, that's what we've been doing since that announcement in March. So in May this year, there was something called the Model ICB Blueprint was published, which set out that new role in more detail. And then by the end of May, we were required to provide an outline plan of how we would deliver those redefined responsibilities, but within the financial envelope that was available to us. I think, again, just picking up the comments from I think it was Nora who raised it, just in terms of the role of the ICB, the Health and Care Act is still extant, it still remains. So in that Act, the ICB has a number of responsibilities. So, to improve the health of the population, to tackle health inequalities, to ensure value for money, and to act to support the wider health and sort of economic and social development of South Yorkshire. So those statutory aims remain. So part of the task when we were required to look at the reduced resource envelope and how would we cover all of the bases and focus on strategic commissioning, those responsibilities remain in place. And the arrangements that we've developed will allow us to continue to deliver those responsibilities as set out in the Act, but through the medium principally of strategic commissioning. I suppose the only other thing that I would mention is in that blueprint, it also identified a number of services that we currently deliver, which are not really a part of that strategic commissioning function. So things like continuing healthcare. We also provide medicine support to GPs. We have responsibilities in safeguarding and SEND, as you know. The steer was that over time we would relinquish those responsibilities and they would be taken on by other organisations. Now, the detail of that has not been worked out, and also some of those changes would require legislative change to make that happen. So, for example, I've got a legal responsibility with regard to safeguarding in my role, and that remains until such time as the Act is changed. So it's a sort of, I guess it's a transitional picture, but legislation will need to catch up if the full direction of the model ICB is going to be delivered. Just to pick up in terms of the impact on clearly my colleagues within the ICB, including myself, we are having to look at every part of what we do. So in essence, we spend about £61 million a year running the business of the ICB, and that includes those services we deliver like continuing healthcare and medicine support to primary care. So to reduce that by 50%, that goes from 61 million down to about 30.2 million, which is a reduction of just over 51%. And it's basically calculated, the envelope is calculated based on weighted population. So there was a figure of £18.76 per head of weighted population, and that determined what the budget of the ICB was. It's been amended slightly to £19 to reflect pay awards, but in essence, the amount of money we've got available is determined by the population size. And for us, it was just over 30 million, which was about half of what we've got. And clearly, our major expense is people. So about half of the people we employ will need to go through an organisational change process to reduce the numbers of people who work for the ICB. So we've got 800 people at the moment. We'll need to move towards about 400. We were hoping to start a consultation with our staff in the beginning of July, and we've been working closely with the trades unions to work out the new structure and to explain what the proposals were, but unfortunately we were not able to do that because of a national discussion about how redundancy costs will be met, and we're hoping that will be resolved in the next few weeks so that we can begin consultation. I have to say that weighs heavily on my mind at the moment because we've got a lot of people who work in my organisation who want to know what this means for them, and you can't really begin to do that until you start consultation and start to work through it. So I'm keen to start as soon as possible in order to give people some certainty. I've mentioned the role, our role as strategic commissioner. So although we're having that change, I do think it's a critical role. And when I look at the 10-year health plan, that ability to really understand the needs of our population, to develop plans and to enact them through our contracts with providers, I think will be critical. But just a couple of things that I wanted to emphasise. One is the importance of places in South Yorkshire. Rotherham, Doncaster, Barnsley, Sheffield have been a really important part of our focus as an ICB, and we've maintained significant teams in each of our localities. Unfortunately, in the new arrangements, we're not going to be able to afford to do that in the same way. There will be people identifiable and dedicated to particular places, but we won't be running it as 4 separate teams that we kind of bring together. We just won't have the bandwidth to do that. But those place partnerships are really important. So we've been doing quite a lot of work with partners in each of our places to get ready for the changing role of ICBs. And there's a national programme has just been launched, seeking expressions of interest to be at the kind of vanguard of the development of integrated neighbourhood health. And I'm really keen that all 4 of our places are accepted into that programme, because I think each of our places has got a terrific story to tell in terms of the work that has been done in those places over many years, with the health and wellbeing boards, with the partners on the patch. And I'm really keen that we don't lose that momentum, we keep it moving forward. So I think it's just to say that those place partnerships remain critically important. At the moment, we kind of we help convene and bring people together. In the future, our relationship will be as the Commissioner of Services. But I do think if we want to commission integrated neighbourhood health, there needs to be structures and arrangements to enable us to do that. I think a sort of corresponding point I would make is we have got some structures that go across South Yorkshire that we currently support, like the acute hospitals, for example, work together as a federation. The mental health organisations do the same, primary care, the VCSE, and we do put resource into that. And whilst we will continue that to some degree, some of those arrangements we won't be able to fund, but we're keen that they continue, particularly the Acute Federation and the Mental Health and Learning Disabilities Alliance, which we can't fund, but we're interested in commissioning integrated services from those structures. So I think probably in essence, I'll probably draw it to a close there, and I'm happy to answer questions. In terms of timescale, the request that was made back in March was to complete this process by the end of this calendar year, so the end of December. The delay in consultation may cause difficulty with that, but that timescale hasn't been altered officially yet. So, but I think it almost seems inevitable that we might have to change our view on that. I think the final thing to say is, one, clearly we work really hard, particularly to engage our people. And I meet, over the last 3 or 4 months, I've been meeting with my colleagues, every week to keep them updated in the progress. But we've also made sure that we've briefed local political leaders, MPs, council leaders, chief executive councils, the mayor, and we've also talked about this in our public meetings. So I think it was touched on at the last Integrated Care Partnership, but also particularly at our public board in July, we gave an update, as I'm doing now. I'll leave it there. There are some slides, so don't worry about the detail. There is detail in the slides, but I'm sure colleagues will have those, but they're not visually particularly exciting, so I think probably just have a look at those just to refresh your memory. Thanks, Chair.
Can you turn your mic on, please? Thank you, Gavin. Have we got any questions? Yes, Councillor David Knight.
Sir, I'd just like to ask, this massive change in the organisation gives concern. How will such a reduction in impact the remaining staff, the governance, and the overall effectiveness and the impact on the communities that we serve?
Well, I think that's it. That's absolutely the question we've been answering since the announcement in May. So I think we've put in place, I think, arrangements that particularly will deliver that strategic commissioning role, which at the end of the day is our core function. So I think we can cover that responsibility, but clearly there's a lot of things that we do now that we just won't be able to do. So, for example, we spend quite a bit of time, I mentioned the oversight arrangements of provider organisations. We simply will not have the bandwidth to do that. So part of the work that we're having to do at the moment is to work with NHS England to just understand those things that we will relinquish because we just won't be resourced to do it, because we need to prioritise that strategic commissioning function, and those things which we expect NHS England and the regional sort of arm of NHS England to take on in our stead. So there's quite a detailed conversation happening about what are we giving up and who's taking that on. But in order to answer your question, the way that we deliver that core function of strategic commissioner is in part by stop doing things that are no longer our responsibility.
Thank you for giving us the indication there, but I'm struggling to understand which sectors may be the most seriously affected. Can you give us a help on that one? So back to, this is the internal arrangements within my organisation as opposed to the services that we commission. So we'll continue to maintain balance across primary care, across acute services, across mental health services from a commissioning perspective. But what we won't be doing is provider oversight or system management with regard to those services. We'll be identifying the needs of the population and commissioning services. But there will be balance across all of the sectors that we have now, but it will be a narrower focus. It will be strategic commissioning apart from, as opposed to those other things that we do now. Thank you for your clarity on that one, Gary. Thank you.
Just as a supplementary to that one, Gary, the statutory stuff that you're going to continue to do through commissioning, and there's an expectation that someone will take that other role on. Well, my question would be in terms of the workforce that are already doing that work. So potentially, with discussion with trade unions, there might be an option for TUPE, where, and have we got a plan for this transition where some things will be TUPE and some things will be redundant or whatever? And when can we get sight of that following consultation?
I think that's a terrific question, actually. So one of the challenges, and this is why, although the delay in consultation is disappointing for the people who work in my organisation, we were sort of ahead of the curve. The announcements around our changes came before some of the detail around the NHS England regional teams, but actually we're more aligned now. So I think there's a greater opportunity for colleagues who are currently doing work within the ICB maybe to transfer to NHS England, but that's the detail that we're working through. So in some ways, although the delay is not welcome, it does give us more time to work on some of those things. I mean, clearly we're interested in minimising the numbers of redundancies as far as we possibly can.
Every time, Gavin, every time. Councillor Lee.
Thank you. Yeah, my question was similar in a way. It's to do with the pause. You've paused now. I'm not sure how long that pause will go on for, but how will that interfere or affect the changes and the new model that you want to arrive at? How long will that take, and what kind of delay would there be? I've got another question as well, but I can ask that once you've answered that one. So
it's somewhat unknown. I think that basically this is a discussion that's happening between NHS England, the Department of Health, and the Treasury, basically about how redundancy costs will be met. The latest intelligence I've got is that we're expecting that an agreement to be reached within the next 2 or 3 weeks. So I'm kind of hoping that we can restart consultation in September, in which case we haven't lost too much time. But it will, I think what I was saying earlier, although there hasn't been a change in the timeline, I suspect it will affect. I mean, you have to consult for a statutory period of time. You have to respond to that. You have to give people notice. So there's just an inevitability, I think, that there will be a delay, but I don't think it'll be a huge delay. I think it'll be a matter of maybe a couple of months, something like that.
And the second question was about Health Watch, because I understand they're being absorbed now into the ICB. So that's Patients' Voice and Influence. How will you manage that, and will there be any conflicts of interest?
That's a really good question. And to be frank, I mean that was in the 10-year health plan, which was published on the 3rd of July. So that, and to be frank, that was unexpected. I wasn't expecting that. And I do think Healthwatch have a really important role, and part of our thoughts about how will we continue to fulfil our responsibilities to listen to the public. We actually had ideas of working even more closely with Healthwatch as a means of doing that, but actually, you know, clearly that's not the case. So I think it's a live issue, and I think, again, one of the benefits of the pause is it's given us a little bit of time to rethink that. I mean, I suppose what I'm saying specifically, have we put enough in terms of engagement and public involvement, given that Healthwatch will be disbanded?
So, are you in discussions with Healthwatch across the region?
So I'm not sure about across the region. Certainly, I mean, in terms of South Yorkshire, yes. So we do. So interesting. We had a conversation like this at our integrated care partnership yesterday. We had a development session. We had colleagues from Healthwatch there. Yes, I think from not from all places, but some were there. We've got. I mean, Healthwatch. They're not members of our board, but they do attend every one of our board meetings. So I think Healthwatch is cited on that. But I think there is some detailed work that we need to do now, given that that latest announcement in the health plan at the beginning of the month.
Councillor Keenan.
Thank you, Chair. I'm going to be a bit cheeky. My question's got two parts. We hear a lot about places, and places is very important to all of us here. But how will the ICB maintain a strong focus on place-based services while operating with such reduced resources? And what role will local authorities, including local scrutiny functions and health and wellbeing boards, play in this new integrated services model?
It's, again, a really good question, very, very live. I must admit, almost, I came back from that meeting in March when this was announced, and immediately sort of started talking to particularly like local authority colleagues about exactly that issue. How do we keep the momentum going? So I think one thing we can do in our new form as the ICB is seek to commission integrated services. So I think it's really difficult to commission integrated services from a disparate array of providers in a place. So I think if people can come together in partnership, so I think we can incentivise partnership working, because that's how we'll want to spend our money, to be frank. I think there's real appetite though in each of our places. So the challenge we put out to put in a bid against this national development programme has been responded to really actively. And it's, that's primary care, it's local authority partners, it's the NHS trusts as well. There's something in the 10-year health plan which is called integrated health organisations. So there's actually a reference to creating organisations from which we could commission integrated services. I suppose in my mind, I'd like to see our place partnerships, they could become those organisations. So I think there's a real prize here, and I think we're well placed. My experience of talking to people up and down the country is, one of the great things about South Yorkshire is the quality of the relationships in each of those places. But things like the health and wellbeing boards, I think I've got an elevated role actually as a result of the 10-year plan. I read that as strengthening the role of the health and wellbeing board, and I think we'll want to work ever closely with them in terms of developing plans to improve people's health in those particular places.
Okay, thank you. Councillor Wright.
Yeah, thank you.
My screen.
Hi, Gavin. How will Bassett Law be served under this new functional model, and will it have a place lead for Bassett Law? So
that's a good question. So the way it works at the moment is that Nancy Fitzgerald, who's an executive member of my team, is the place lead for Doncaster, and obviously the trust Doncaster and Bassett Law includes Bassett Law Hospital. So that tends to be how we kind of I suppose engage with that organisation. In terms of commissioning for the people of Bassett Law, that's principally the responsibility of the ICB in Nottinghamshire. So we don't commission services on behalf of that population, but we do have a relationship because the acute organisation, at least, that provides services into Bassett Law is sort of on our patch. So it's a little bit of a complication, I'd have to say.
Yeah, okay. this was written ahead of the of publishing of the 10-year plan. We now have the 10-year plan. How does this inform your approach to each of these risks you've outlined in the report?
So interesting. One of the things we've done is a sort of a kind of gap analysis, and one of the reasons we were meeting with the Integrated Care Partnership yesterday, which is effectively representatives from the 4 health and wellbeing boards, the Mayoralty and the ICB. One of the things we've done is to kind of look at, try and answer that question in a systematic way. And actually, if you look at the health and wellbeing board strategies that exist, and also the integrated care strategy that we developed collectively, I mean, I think this is heading in our, I think we're heading in the right direction. So there aren't that many things that I look at and think, actually, we've missed something. I think actually it's probably the other way around. There are things that are not as strong as I would have liked to have seen them in the 10-year health plan. So things like health inequality, for example, or there's a big focus on digital and AI and all of those things, but there isn't much about digital inclusion. So I think there are things that we're thinking about that are actually missing. So I think part of it will be taking what's in the 10-year health plan, but also kind of, some of the work that we're already doing. We've done a really fascinating piece of work with Sheffield University through something called the Health Equity Panel, and we had a presentation from Professor Alan Walker yesterday, the academic who's been leading that work. But it's really about where should we focus our efforts in terms of tackling health inequalities. Now that's not. I think that could have been stronger in the 10-year health plan, but we don't want to lose that. So it's not. So we'll do what's in the 10-year health plan, but that's not all we're going to do. And I do think those. I don't want to be too controversial, but I think the 10-year health plan is really a 10-year NHS plan. And I think if we're really going to move the dial on the health of people in South Yorkshire, it's got to be more than that. I mean, the NHS has got its job to do, and clearly we've got work to do. We're not. I don't think we're performing as well as we ought to be. But those wider determinants of health, housing, education, community safety, all of those things are critical jobs. It's been a big focus in South Yorkshire, the work in health agenda. So I think it's the 10-year health plan, yes, but it's not exclusively that. I think there are other things we want to do as well.
Thank you.
Okay, I just want to return back to employment and morale of staff. Potentially then, if I'm right, we've got a core of staff who will be safe because that will be the 50%. We've potentially got a number of staff who could be TUPI'd into other employment. But the cohort of staff who are at most at risk, have we got a plan? We know that there's issues about recruitment in NHS. Have we got a plan where they could be successfully recruited into other parts of NHS with some protection?
So, yes. So the answer is yes. We're working on that, but I think it is it's quite. I'm sorry to say, but it's a really difficult environment. So although the ICB has been asked to reduce its costs, interestingly, the provider organisations, the other NHS organisations, not to the same degree, but have also been asked to reduce their kind of running costs as well. So when we did I don't know, you probably remember we did a running cost allowance reduction of about 30%. It was about 18 months ago. It was very difficult to do. But at that time, we were able to support people into roles into other organisations. But I think the climate is more difficult. So Christine Joy, our Chief People Officer, is working with all of the HR leaders in our other organisations to try and do that as well as we can. I think there's another piece of work we could do, which is about letting employers more generally know that there will be 400 or hopefully somewhat less, but there'll be significant numbers of highly trained, able, capable people coming into the labour markets, and could we help facilitate them secure roles in other places.
Thank you for that. Now, when we looked at positive opportunities, you talked about relationships and health and wellbeing boards being one positive items that's come through because of the work you've done previously. What do you see as potentially the most negative outcome of this exercise?
Well, I mean, clearly, I mean, I can't get away from my principal anxiety at the moment is the people who work for me. I mean, you know, this is not, you know, whilst I understand the direction of travel, and I understand the desire to streamline arrangements and to, you know, to work in a different way. So that's, you know, that's entirely, you know, in the government's ambit to make those sorts of choices. They're a democratic mandate. But my primary concern at the moment is looking after my people. I think, you know, managing the transition from where we are now into quite a different role, which requires some other people to change as well, whilst keeping our focus on the really important work of commissioning services for local people. I think that transition will need really careful management. But there are opportunities as well. I mean, the place thing actually, I think, is really exciting. I mean, genuinely, and I think in South Yorkshire, I think there's just such good work that we could, you know, we ought to be leading the way on some of that.
Thanks for that, Gavin. Is there any more questions before I move to the next item on the agenda? No? Well, thank you very much, Gavin. We'll give you time to do a soft shoe shuffle. Right, welcome David, welcome Govinda, welcome Katie. We've got a question on this. We've got Nick Trott who wants to ask a question. So what I'm proposing to do is for Nick to ask the question, for yourselves to respond today if you can, or if not in writing. And then I've already explained to Nick that he can stay after that as an observer, and that will not be a problem. So we'll move to Nick Trott, please.
Technology. Thank you so much. I just want to express gratitude to the committee and the chair for letting me attend at such short notice. I promise I'll be brief, but hopefully you'll humour me with just a little bit of context very quickly. For those who don't know me, my name's Nick Trott. I'm a gastroenterology dietitian from the Hallamshire. At the Hallamshire, we have a gastroenterology unit that's dedicated by NHS England as the National Centre for Complex and Refractory Celiac Disease. I'm also very grateful to Govinda for his excellent summary of the issues around gluten-free prescribing, and I hope you've all had an opportunity to read that document. Govinda highlights the issues around celiac disease, which is a complex, common, underdiagnosed autoimmune condition for which the only treatment is a gluten-free diet, lifelong. Govinda highlights the issues around non-adherence are in the moment in terms of symptoms, debilitating symptoms, lack of ability to work, engage with activities of daily living, and long-term symptoms of reduced bone density, vitamin mineral deficiencies, increased other autoimmune conditions, subfertility, neurological issues, and for a small subset, increased risk of small bowel lymphoma. I think because it's so well highlighted, and Govinda goes into the issues and the challenges with a gluten-free diet, I'm trying to understand why option 4 of complete suspension of all adult gluten-free prescribing is the preferred route. We have been down this before, and the question I want to highlight is the rationale and justification for this is now I would say no longer evidence-based, both clinically and the data, that gluten-free foods are more available in supermarkets, its accessibility. Who will be most affected by this are people who can't access those things both financially and both geographically. Also, the justification that a gluten-free diet can be followed with just gluten-free foods alone does not represent that these products enhance social inclusion. We have a very diverse population in Sheffield, and people rely on these products to have a food-related quality of life. Relying on naturally gluten-free foods reduces intake of calcium and iron, which can increase bone density loss and lack of ability, increase anemia. The also issue is the justification that these foods are ultra-processed. Ultra-processed is a nutritional dog whistle, in my opinion, in this context, and shouldn't be used as a justification for non-prescribing of these foods. We need to think about dietary patterns. And also the idea that we're going to increase inequality and reduce postcode lottery by the suspension of these prescriptions. What we're going to do is enhance inequality. And we've seen these arguments come up from Leicester, ICB, where the prescriptions were stopped, from the Isle of Wight, ICB, where the prescriptions were stopped, where Nottinghamshire, where the prescriptions were stopped, and it's all on the same justifications that I've just highlighted. And I think if we are going to down this route, we need to move away from these, what I would describe as assumptions and non-evidence-based decisions for stopping prescriptions.
Thank you for that, Nick. Can you turn your mic off, please? Do you want to respond to that today, or do you want to respond to that as part of your presentation, Dr. Crichton?
So if we can present what we've got today, I think that this is part of a process where we're not making a decision at this point in time. So I think we can liaise with Nick. We can, because part of our further engagement was to seek views of professionals, members of the public and others. So we hope that we can pick up some of that today, just because we had that in our presentation, and then we can respond formally through here. If you could help us with the capturing the sort of statement and questions, that'll help us and aid that, so we can tie both things together. So that was my suggestion. If Nick's happy with that, then
well, that was going to be one of my questions about, have you consulted consultants? So you'll be answering that as well, so not a problem. So shall I move directly to you then, Doctor? Yeah.
So I'm Dr. David Crichton. I'm here for the next 3 items, so I will make myself comfortable here, and I've plugged myself in and got some electricity from you. I'm the Chief Medical Officer at the Integrated Care Board. I'm also a local GP in Doncaster, so I also practice and see patients that are affected by the condition we're talking about today. I suppose, following on from Gavin, one of the things that sort of drives some of our considerations is the financial challenges that are faced across the whole country within the NHS, and particularly us in South Yorkshire. So we're very mindful that we don't make decisions just based on finances, but they are very much at the forefront of our minds, and we do need to consider value for money. So I think that will be reflected in certainly this item and the next item. Today we wanted to give you a bit of an update on gluten-free prescribing, because it's not the first time it's been brought to this committee, and in previous iterations as CCGs, clinical commissioning groups, we each had different policies, and one of the first things we did when we brought the CCGs together was to unify the policy across South Yorkshire. So people who have been members of this may recall that and be be mindful of that. So that was a point in time. I said we are at a position now where we are considering this topic again. I think Nick highlights some important things. I would just like to take a moment or two just to remind people who are not so familiar with this. So gluten enteropathy is a condition that is a lifelong condition. You're not born with it. Usually it develops over time. To be honest, we don't fully understand why people get it, because it's an autoimmune condition, so something changes in the body to change how we react to that. And gluten is a protein, so it's found in food products such as wheat, rye and barley, and it gives it structure, so that gives you a bit of a background there. So the commonest condition that people may be familiar with is celiac disease. So celiac disease is a disorder of the bowel, and it certainly is significantly affected by not being able to utilise the gluten in the diet. Of course, it's found in many products that you'll be familiar with, so bread, cereals, and items like that are very common that you'll find gluten. But of course, there are lots of things in our diet that don't include gluten. So your meat, fish, vegetables, rice, potatoes, those are things that actually gluten is not contained in, thankfully. We have identified from our general practice register about 0.5% of the population who have celiac disease, but actually nationally it's suggested there's a 1%. So my first response to Nick really is that one of our challenges we have across South Yorkshire is actually making people aware that celiac disease may be something they're affected by, because if you're not aware of it, you can't do anything about it. So as well as tackling and giving support to those people who already have it, I think it's important to know that I think out with the paper today, we do need to work together with the specialist to look to rectify that. There are other rarer conditions which has also been referenced where it can affect people neurologically, and other skin conditions are associated with this, but the majority will be celiac disease. I'm going to pass you over to Gov. Gov's one of our Medicines Optimisation Programme Directors, and he's pulled the paper together that we've presented, so he'll just run you through some of the key elements of that. Thank you.
No problem. So, everyone's seen the paper, so I don't know whether you want me to take it through bit by bit or just head straight to the options. What's your
wishes?
like?
Shall we just let it flow? Yeah? Yeah? We're happy at that?
Yeah? Okay.
Yeah.
No problem. So, as you can see from the paper that Sheffield, South Yorkshire ICB is quite high in our prescribing of gluten-free breads and bread mixes at this point in time. So work that we're doing, we're looking at prescribing overall, and the amount of the cost of prescribing was to have a look at gluten-free as part of the overall ask. So this, as David has said, has been looked at a few times in the past. So the last time was a paper brought before this committee in 2003, where the ask there was to see if we should standardise and unify gluten-free prescribing across South Yorkshire. That was achieved and has been done so far. So right now, in the paper, option 2 is the as-is option. So that is, we prescribe gluten-free breads and bread mixes to the population of South Yorkshire according to the CELAC UK guidance of how many units we should prescribe. That's fine. So going on from that, it's now looking at whether that is still the most appropriate thing to do in the current landscape. So this is an update paper from the 2023 process, just making sure that everything now reflects the 2025 aspect of it. So as you can see, the paper goes through cost of living and how we are compared to other ICBs around us. So the paper highlights some of the ICBs of our neighbouring that have changed their policies around gluten-free already, and there's some highlighted in the paper. From that, we've highlighted some options that we're proposing as to which way we think gluten-free could go, subject to more consultation and engagement processes. So option 1 would be to, like some of our neighbouring ICBs, restrict gluten-free prescribing to those most at risk of becoming malnourished and not adhering to a gluten-free diet. Option 2 that we've got so far is to remain as is. Option 3 would be a reduction in some of the amount of units we can prescribe. So that's reducing by 1/4, so 3/4 of the current prescribed volume of breads and mixes that we're giving out at the moment. And option 4 would be to restrict prescribing to those under the age of 18 only. So there's financial aspects of that within the paper as well, to show what the outcome of each of those options would be. And then we go on to how, depending on the option that is chosen or followed, we would do then further engagement on that specific option going forward.
So just to come in on the back of Gov then, so I think our Bassett Law colleagues have identified, I mean, they're part of Nottinghamshire. Nottinghamshire are one of the areas that have taken a decision prior to this to restrict further. West Yorkshire have almost no prescribing of gluten products. I know that our other neighbouring colleagues in Humber and North Yorkshire are reviewing this as we sit here. We have excluded the no prescribing at all within our options, but I want to make that clear that some ICBs have gone down that route. We have, for reasons of our commitment to starting well agendas, which I think will sit within many of the local places, we feel that while you are growing as a young person, that the importance of having the right nutrition to aid that. And actually my time working in paediatrics was that failure to thrive was actually one of the signals that people may be celiac. So that was something we would clearly want to avoid. So that was some of our rationale. There is no hard and fast thing. This is a judgment call. So I look to Nick and say that there's a balance of all the things we have to consider, and it will be quite a challenge when we do take this to our board for a decision about where we might go get behind the options. Kate, I just wanted to just check and say, with regards to the engagement that has been undertaken over many years, I suppose that the role of the committee here today is we welcome a bit of a steer of, based on the work that's been undertaken previously, the point we're at the moment, we welcome views of people around. But Kate, is there anything else you want to pick up, please?
I think just to say that within the paper, one of the things we hear when we work in citizen involvement all the time is that, you've already asked me this question. So what I wanted to do was bring the committee the body of evidence that we'd amassed in the various exercises we've done over the recent years in South Yorkshire, talking to our population about their views on this, because we have looked at it a number of times across the South Yorkshire patch. So hopefully you've seen the paper that highlights that. Just to also say the reason that the option 4 has been added since the 2023 look at this is directly as a result of the citizen feedback that we got, because people said to us, as Nick's referenced, in terms of sort of societal inclusion, it's particularly hard for children not to have the same lunches as their peers and to feel very different from their peers. So that was added as an option because we recognised that that was the feedback that we heard recently when we spoke to the population in South Yorkshire about this. And I suppose the other thing is really just to reference the fact that we are committed to making sure that we do hear from people and we use that feedback to help us determine what the next steps are and what people in South Yorkshire would really want us to do about this issue. But also mindful of the fact that we have had this conversation quite a lot of times, so we are really clear that we need to make sure we're asking the right questions of the right people to make sure that we're adding more to this and informing this debate rather than just rehearing the things that we've already heard.
Okay, thank you for that. I'll open it up for questions. Have you got any questions? Yeah? Yours first? Mary.
I guess my question is about how people live their lives with this condition. In terms of just their social lives, the work life, all those things. And I know somebody who has this condition who really has difficulty. She can't get the right food in a restaurant. She can't get the right food if she goes out. I bought a sandwich in Greggs today. That would be impossible for her to walk into a sandwich shop and get a sandwich. There's no guarantee that anything would be available. Life is very difficult in terms of that. In terms of health inequalities as well, I know in certain areas, it's this kind of gluten-free bread is not available. It means long journeys to supermarkets where availability may not always be there. Things run out, shelves run out, the shelves are empty. So if people have got the fallback of having the prescribed bread, the prescribed mix in their homes, isn't that going to make life much more easier for them when they've got all these other demands and all these other problems that they have to face day to day with the condition that they've got? And I'm just wondering if people, you say sometimes people don't eat the prescribed food that they should have, they maybe then eat food that isn't the right food for them and their condition. Doesn't that mean that they will be at greater risk of falling back? And like colleague over there said, there's a big risk for some people if they don't have this kind of food regularly and prescribed for them, that they will then slowly deteriorate, and sometimes the deterioration isn't recognised until it's gone past a certain point.
I don't think any of us are saying the impacts of having a condition like this. I think the other dietary condition people will be aware of is diabetes. It is life-changing. Once you get diagnosed with this, it will impact upon you independent of the prescriptions as well. So the prescriptions are one way of supporting people, and as we have highlighted, it is quite limited at the moment. Outside of that, thankfully, as time goes on, we are seeing more availability of gluten-free products, and actually some of the things that we eat actually are gluten-free. So they're just You know, they're things that, you know, will benefit all of society, and we don't need gluten in our diet to survive. So you will see more and more availability of that. But I think that has been raised before, particularly in some of our communities where, you know, big supermarkets have quite a big range, but if your local shop is just a small convenience store, then they might not be so well, you know, well stocked up for this. The health inequalities, go back to my previous point, is the biggest health inequalities those people who don't know they have it. So I think we've got a task ahead of us to educate and support people, you know, within some of the communities, even before we're thinking about treatment, about actually making diagnosis. So I know that's things that's come up. We're very mindful of that. As the Chief Medical Officer of the ICB, I don't come here lightly. This is not an easy decision, even to bring it to the committee today to say we're having to consider this. It just reflects the, you know, kind of where we are within the health service and the difficult choices that we're having to make. And there are lots of things now we're having to consider that we probably in the past wouldn't have thought of. But such as the times that in the Integrated Care Board, we are having to look at everything that we do and review our position. So I'd be kidding people if I said there wasn't an impact of any of the decisions that we're bringing this afternoon. There undoubtedly will be. And as I say, we need to take them in a decision with our conscious, awareness of actually what the impacts of anything we might decide. As I say, we're not making a decision today, but we do welcome points like that for us to feed into any further work that you might suggest.
Okay, thank you for that. Councillor Wright.
Yeah, thank you. Hello. Speaking in terms of prevention, is there anything to mitigate the risk of non-prescribing will bring about health conditions in affected individuals that are more expensive for the system?
That's a tough question, that one. I mean, education and training I've highlighted. I mean, you know, there are gluten is found in many products that aren't obvious because the food industry, you know, produces them on a large scale. So I look to colleagues like Nick, and it's probably impossible to avoid gluten completely. So you know, that awareness and education once you have the diagnosis is probably a key element to this.
Yeah, absolutely, and that's what we're doing. I've reached out to dietitians from South Yorkshire to help with this. So whichever way we're going, like David has mentioned, raising awareness of gluten intolerance is something we need to do. You know, we've got 0.5%. Technically, it probably should be higher. So I think the education part of this is key to helping mitigate anything going forward. So if the decision is to choose under 18, then we focus on how we educate our children to understand if this is the case, what to do going forward, and help hopefully a longer spell of avoiding gluten will prevent things happening in the future. You see what I mean? So it's mainly about once we do this and go down any path that we choose, even if we do or we don't, whichever way the process goes, it's about ensuring that the education and awareness of this is improved.
Okay, thank you.
Right, thank you for that. Councillor Knight.
Yeah, it's a very large topic to come into today, and very serious from what I see from what you've got to try and achieve to on your side of it, and looking at you've raised 4 options here as something to look at, obviously. Now, I did notice, and I'd take a priority on food products available in Tesco's and Waitrose as an example. Now, historically, the shelves, should I say, had limited amount of products available, and quite often, as the lady did say, they quite often used to run out. But I notice that these days the product range is wider, but also it is more available but only, as you say, in the larger stores, not in your corner shop, which I think is something we tend to accept. But I also noticed as well that the cost of these products has come down quite considerably from where it was maybe 10 years ago against where it is now. I took the price of a basic small Tesco one, for example, against price for price. The price difference was 15 pence. Although I then looked at Warburton's as another one, their price difference was £1.10 on a loaf of bread. Okay, so financially, things have come more back into line for the celiac proportion or element, or the 1% that we've got within our community. With that in mind, I looked at, and that sort of asked you to sort of look maybe as well, the age group, which we were talking about, the 18s and unders, which was looking at the option 4 as an example. They're the ones who are the young ones that are growing into understanding where they're coming from and having to need to sample what they can sample to find what their physical body will accept. Because I know that I understand there's different levels of celiac in what certain bodies will accept and others will and others won't. You know, some bodies will accept a degree and others will completely reject anything. So again, I think there's more time needed to be looking to the consultation between yourselves and the gentleman at the other side who you're at the helm, should I say, of the whole thing, and between, at the end of the day, trying to achieve a happy medium that's workable, whether it's a reduction in the amount that's given or offered, or to go to the option 4 as another option, and say, well, it's the younger age group that needs to be brought into understanding to the age of 18 or whatever, who can then thereafter know what they can eat and what they can't eat as to match their diet. But in the younger age group, I think they still need to have that opportunity to try different products and to get to taste and to enjoy. Because as I described it, when I tasted it before, it's like sometimes having a slice of sawdust. That's taking it as an extreme sometimes. But once you've got used to eating bread of that style, which is more readily available, it's like eating German bread, for example. It's a parity, should I say. It's a similarity. It's what we're used to. We're used to eating the white, brown breads, rice or whatever. But again, it's what we're used to. It's not what another person might be used to. So I asked really is that could you consider the options again that you have in front of you in line with the gentleman from the hospital side, where he's at the helm of it. You know, he's seeing the people on one hand, and on the other hand, you're having to see the finances. So hopefully, with a bit more consultation between yourselves, try and find a parity if we can, please. I'll leave it with you to come back on that one.
Are you taking note of that comment? Yeah. Are you going to respond?
No, it sounded like it was more of a comment than a question, so I think we'll take note of that, thanks.
Right, well, I've got a question. It's about consultation. On page 75, there's a mention that there were only 89 people took place in the engagement, and they were from Doncaster and Rotherham. I'm wondering about the engagement with Barnsley and Sheffield.
Yeah, I think at the time we were looking at, because it was when we were CCGs, and so we were looking at who would be most affected in terms of where places were at the time. So it was those areas that were likely to be most affected should we decide to align. There was also the fact that Sheffield had been through quite a big consultation because they'd already changed their position. So I think going forwards, we acknowledge that it needs to be more of a whole South Yorkshire exercise.
And taking note of what Nick Trott said in terms of the people already diagnosed, and we got a proposal to speak to those as well, and to widen remit, because I know that David talked about education and raising awareness, and I think the more education and raising awareness that we produce, the more knowledge and understanding that people will report it to get the diagnosis, if you see what I mean. So it's putting all those ducks in a row to ensure that we've got the proper consultation at end. Do you agree with that?
Yeah, absolutely.
I like yes.
Yeah. Leave it at that, just yes.
Yeah, Councillor Lee.
We talked about availability of the correct products in supermarkets. So what discussions do you have with food producers and supermarkets about what they should be stocking and how prevalent this problem is and how they can cater for those people who are probably quite a significant number, really, because you've said that some are mildly affected, some more severely affected. So what discussions take place? The government advises supermarket and food providers on all sorts of things, so do they advise on this?
So in previous work we've undertaken, we have worked closely with the Celiac UK, and I think we would look to them as a sort of national representative body to lobby, you know, wider than us. I think I've got to be realistic, as in my role as the ICB, it's probably limited with regards to, you know, impacting on global supermarkets. But I think, you know, as I said, it is about working in partnership across, you know, the specialists, you know, the charitable organisations, us as a health, and our communities. So I think there are opportunities for us to do more. One of the things that Gavin was referring to about having an integrated care partnership was that our discussions with the Mayor and the Health and Wellbeing Boards is we feel like we've got a bit more weight than we did, you know, coming from the clinical commissioning group in Doncaster where I previously worked. So I think there are opportunities for us to strengthen that. As you know, Councillor Knight has highlighted, there is more availability and more variety than we've seen before, but clearly we've got a long way to go for it to you know, be across all you know, retail establishments and that. So I guess it's a piece of work that will continue.
I think the other thing just to say as well is one of the areas when we've spoken to people in the past, obviously this has the potential to disproportionately affect people on low incomes. So we're really mindful of food banks. So we've done some work in the past where we've been into food banks, and we know that the availability of gluten-free products in food banks is lower as well. So I think there's an opportunity there for us to do some work with some of the local food banks as well.
That just brings me on to my question in terms of opportunity. Because when we look at the 4 options, if we look at option 4, which you suggested, that takes away the opportunity for option 1, which is the people who are most vulnerable. And that would be part of that criteria. But we've also got it where everybody who's been consulted agrees that we should look at reducing the level of expenditure that it's costing to deliver this service. So we've got some uniformity there. But we've also got in the paper the Wales option, which would be a voucher scheme for people who've been prescribed, where they could take that to the place of their choice to get produce that is more readily available. However, it potentially would cost less than a prescription charge. So what's your thoughts around that?
So we are restricted to what we can prescribe at the moment to purely breads and mixes. That's all we can give out in terms of gluten-free. So even if we used a voucher system, it'd be with the same restrictions. So you could take your voucher to wherever, but they'd still be restricted to whatever or whoever had that bread and mixes on offer. That's a national guidance. It's NHS England has already put that in place, I think back in 2018, if I remember correctly. So the voucher system is available. That would be a different way of getting hold of breads and mixes, but it would still be just the breads and mixes that people could get hold of. I mean, at the moment you can get them from community pharmacies on a prescription, which are quite local to lots of people anyway, but it's still bread and mixes. So a voucher system would be an option. It would have to consider how much that would change compared to an electronic prescription which could be sent to a pharmacy, and the differences in that, and that's a stretch. But yes, it is an option that's in there.
It's something we could certainly have another look at. We know that Humber and North Yorkshire did run something, or York did run a scheme similar to that. So we know there's others that have had experience, and we could get some learning from them. Councillor Stowe, you did mention about health inequalities, and I think we do, boiling down to prioritisation, there's nobody more a priority than young people. So I think that is a subgroup of people that are classed as vulnerable. So I think what we wouldn't want to see is poverty in a family, and children not being cared for, and as I said earlier, not having a blanket no prescribing just wasn't palatable even for us to come here and suggest that, and I know other areas have gone down there. As I say, not to take away the difficulty of the final decision here, I think we've committed to, through the impact assessment, liaise with those people who've been impacted upon with this. So that would have been part of the work we planned to do anyway. So you can be reassured that that's the plan. I think I've heard from colleagues, and I sort of saw a few nods around, is time to consult has been suggested by the committee, reconsider the options, and then really thinking about the impact of a summarised, the sort of general consensus that people have here.
Just to confirm my position, I was taking young people as a given, and it weren't excluding young people at all. And when I was talking about more vulnerable people, it is people who aren't young people that do need it for their life experience and their knowledge and their future health. Okay, if there's no more questions, I'll bring this to a close and move to the next item. And we've just got one more question. We're talking about consultation and timescales. Have we got any timescales that we're working to, or will that be part of consultation?
I mean, the question today was to seek about whether we needed to go out and do more formal consultation. I think picking up what you're saying is time to consult. I'm implying that you'd suggest that we did continue that process.
Well, I'll move in recommendation, and our recommendation is that we consider update and welcome update. We don't recommend any of the options because in our pre-meet we've got different views on different options. So it's all options are still open, but we recommend it, and thank you, and we'll take a vote on accepting the work in progress and look forward to future consultation and then coming back to us at the appropriate time to feedback in. Is that okay? Is that acceptable to everyone? Are we okay with that?
To indicate when?
And do you want to indicate when?
Or not? Do you want us to? Are we meeting again in October?
I think we were hoping to get a steer because, as I say, the balance of our pressures that we had, we want to do it in a timely manner. I think,
Do you think you'll be able to do a consultation during an holiday period through August when quite a lot of people aren't available to be consulted? That would create some difficulty, wouldn't it?
I think there's nothing stopping us starting a consultation. I think what you're asking us is what period of time would we undertake that over? I look towards, people like Katie to guide us within the organisation as our involvement lead.
I think our organisational board meets, I think September, as you've recognised, would mean we were only engaging with people over the summer holiday period, which would be very tricky. We would meet again in November, so I think we could potentially look to make a decision in our November board. That would give us a fair period to engage with people. I suppose it's just how we then bring that back here if we were looking to do that, because obviously we'd want to get your views on that prior to us taking it to our board.
When in November do you meet? Third Wednesday.
The first Wednesday. We meet alternate.
Work with our team, and we'll
That's
try
fine, because
and
we might
get
have the same discussion with the next item. So shall we pick them up both together and then see if we can work something out
and see if we
between
can
us
work
to help
something out.
us?
Yeah, because
progress
our
that.
meeting's in January, which is behind your timescale, and first meeting in September will be 4th, which is pre your timescale. So we'll try and find somewhere in between. Okay, thank you for that. Right, we'll move on now. If everybody's... we took that vote, didn't we? Yeah, everybody nodded. Yeah. Okay, we'll move on to the next item on the agenda, which is item 9. It's the engagement plans for potential changes to the IVF policy in regards commissioning cycles. And we have got some slides for this, I'm led to believe, so... welcome, Lisa. I'll not welcome Katie and David because I've already done that. And if we can get the slides up, it's over to you.
Thank you. So I'm Lisa Kell. I'm the Director of Population Health Commissioning in the ICB. I have pulled some slides together just so that it helps us just focus on the key points in the paper. I'm conscious that it's quite a large paper with all the attachments, so I will run through them and then we can take questions as we have been doing this afternoon at the end. In vitro fertilisation is a kind of a productive technology, assisted productive technology procedure. It supports, many couples in order for them to be able to, conceive where they're having challenges with fertility. I think it's a relatively common procedure, both funded in the NHS and privately funded too. The aim really of the discussion today is to update yourselves, the committee, on the re-review that we are undertaking for the commissioning policy for IVF in South Yorkshire. To give you some background and some context and rationale for why we're undertaking that re-review on cycles, and also looking at the kind of overview of the national sort of guidance, clinical guidance from NICE on what they recommend for commissioners to fund for their populations. We'll also give a summary of IVF cycles that are commissioned nationally by the 42 ICBs across the country. We'll talk about plans for engagement with our public in South Yorkshire, and then also to request your feedback and views, particularly about the consultation and engagement process that we'll come to shortly. Next slide, please. So our current commissioning policy for IVF has two parts to it. One part is the access to fertility treatment, and that's a policy that's delivered and led by our fertility panel that sits across Yorkshire and Humber. That fertility panel are a group of clinicians and experts within the field who look at all of the kind of guidance from NICE and from other good practice and kind of areas of focus that we should be looking at around making sure that we're adopting the national requirements. The other part is about the number of cycles, the number of IVF cycles. So in all ICBs, it's the decision of the ICBs about what cycles that they are prepared to fund. I should also say that the policy for the fertility access to treatment is it's been adopted by all of the Yorkshire and Humber ICBs. So there is no difference across the region in terms of the access criteria for couples wanting to seek fertility treatment. In 2022-23, the ICB undertook a comprehensive review of its commissioning policies to consolidate them from what were 4 CCGs into one new organisation, the ICB. And we did that comprehensive commissioning policy kind of programme to make sure that all the policies, of which IVF was one of them, was equitable and fair across all of our 4 places within South Yorkshire. In March 2023, the board approved, following the outcome of the review of the IVF part of that consolidation process, we agreed to fund 2 cycles across the board for all 4 places. And that meant that it took Sheffield from 1 cycle to 2 cycles and maintained the current position at that time for Barnsley, Doncaster and Rotherham at 2 cycles. So effectively, we commissioned from 2023 2 cycles for eligible couples. So this year, as we've heard on a number of the presentations that we've done today, the NHS has been asked to prioritise its core services. So, you know, obviously they include A&E and primary care services, GP appointments, secondary care operations, and the things that, you know, obviously we need to be ensuring our population have timely access to and a good quality service. We've heard already with Gavin's presentation and the discussions that we've had over the last 2 items around the kind of statutory duties that we have to deliver from a financial point of view, and we have to live within our financial means and allocations that we get, making sure that we can deliver the best outcomes for all the services that we commission for our population, and that we can ensure that, you know, we're commissioning and providing the services that mean the most to our communities in South Yorkshire. Our commissioning policies must demonstrate the 4 core purposes of our ICB that Gavin talked about in his presentation, and also kind of best value for money, responsiveness to community needs, and the investment in prioritised services and high impact care. Next slide. So that's the kind of background, and I wanted just to share with the committee some specific statistics on what sort of IVF cycles look like at the moment. So this data on this slide is relatively recent, 24-25. So the box on the left demonstrates the number of cycles kind of across the 3 options, so 67%, 19% and 10% for 1 to 3 cycles. And then I thought it was helpful, I couldn't fit, unfortunately, the names of where sort of the regions are in the map, but I think it's quite clear the dark blue parts of the map are 1 cycle, the mid blue is 2 cycles, and the lighter blue is 3 cycles across the country. Next slide, please. So from a NICE guidance perspective, women under 40 are recommended to have up to 3 full cycles. Women aged 40 to 42 are recommended to have 1 full cycle, and the difference why that's 1 and not 3 is that the success rates of fertility treatment and IVF tends to fall the older that you get, but also the more cycles that you have too. And if you, as a couple, have already had some self-funded or other IVF cycles, and that's also taken into account as well. The IVF guidance for NICE is due to be updated, but they haven't given a date on that yet, so this continues to be the principal clinical guidance that we use for IVF. The next slide just demonstrates, with the data that we have available, the effectiveness of IVF by age group. And again, these are national figures from HFEA data. And that shows really quite clearly, I think, that there's a decline in success rates for women by age with their fertility cycles and the treatment that they'd have. In South Yorkshire, the bottom table demonstrates the number of couples that are progressing to a 2nd cycle. So we have a relatively good percentage outcome for first cycle. And I have to say that from listening to fertility consultants in the work we've done over the last few years, it's quite a gruelling regime for women to go through a fertility full cycle with their embryos and their egg harvesting. So it's often, even where it's offered, it's quite something that may not be taken up just because of the difficulty and the impact it has on couples. But it's interesting to just show there that from a second cycle perspective, largely within the range of 25 to 33% of couples that are eligible go on to have a second cycle at the moment. And approximately, we think there's, we're updating this data at the moment, but there's about 200 people at the moment having IVF within South Yorkshire. In terms of the activity and cost, so I'm currently refreshing this with the team back at the ICB. So the data that we had from the 2022-23 review shows that at that time we were spending £866,000 on fertility treatment, IVF cycles, and the really comprehensive EQIA quality impact assessment is currently being updated as well. So that will make sure that it reflects all of the kind of latest guidance, the latest information, particularly in health inequalities, and the impact on our populations of any change we might make. Just thinking about then the public engagement plans, and so I'll probably look to Katie as well to come in on this, but we didn't engage last time when we changed the policy to 2 cycles because it was advantage, you know, it was an improvement on the existing service, because Sheffield was essentially, you know, increased to 2 cycles, and we therefore levelled up the whole of South Yorkshire. And we went out and did some engagement, but not consultation. We did quite a bit of comms, but it was a well-received recommendation and outcome from the board. Because it's different, and we recognise that we do need to do engagement with our population. We're proposing, with the materials and the documentation that Katie and her team have developed, that we do undertake an engagement process. And at this stage, so whilst I've heard the conversation from the last discussion, we've suggested a 5-week consultation engagement period for us to be able to engage with the population. That would put us to an end date of the 29th of August, and the plan is to send the presentation and to be able to provide recommendations to the board in September in public. I think the next slide just shows the materials. There's quite a lot of different materials. This is just an example snapshot of what we'll use to support that consultation and engagement process over the period that we agree. And then I'll just move on to the recommendations, if I may. So from the committee's point of view, and just to accept that the work is underway. We're not here to make a decision, but we do want to get your views about engagement and consultation on the kind of next couple of months. And just to note also that the fertility panel have updated the access to fertility policy. It's had some tweaks to it, but it still is about NICE guidance, and it's not deviating from that. So that isn't really going to, I think, give much of an impact to couples. It's more on the cycles. So if I can leave it there, please, Chair.
Okay, thank you very much for that. Have we got questions? Councillor Knight.
If I may, please. You talked about consultation and consultation. I'll just put it here so I've got it myself here. Who is being consulted? He refers to the healthcare professionals, the citizens of Yorkshire and other local interested parties. who might the other interested parties may be.
Yeah, so what we tend to do when we do an involvement exercise, particularly when it's something that can affect such a large section of our population, because essentially we have to involve the public, anybody who is directly affected or anybody who might be affected. So of course that's any women up to the age of 40. So what we tend to do is the sort of the broader, let's get this information out there and give anybody the opportunity to comment via sort of social media and our media and things. But then what we also do is try and do some more targeted work with the communities that we know are hesitant to come forward, just from seeing authorities and organisations like ourselves putting surveys out there. So some of the more targeted work will be with some of our more seldom heard communities, and particularly with the communities that the equality impact assessment will identify as those who might be the most disproportionately affected. Health inequalities wise, obviously deprivation is one of the most obvious ones with this, because if you can afford it, you could potentially pay for a second cycle yourself. If you can't, that takes that opportunity away from you. So we definitely want to do some more targeted work with people from more deprived communities to understand what the impact of taking this decision might be on them. That answers your question.
Yeah, thank you for that. It's very difficult, as you say, when you look at deprived areas against giving them one opportunity or two opportunities, and the age group in the middle. I appreciate, and I do thank you for your reply, but also, as I look forward to that consultation with people being extended as you've just suggested. Thank you.
Okay, thanks for that. Councillor Lee.
Yeah, I just want to know a little bit more about how you're going to carry out the consultation and engagement in more deprived communities, and particularly Labour communities as well. And, you know, a lot of these communities are indigenous poverty, so, you know, just putting stuff on social media and online is not going to make it at all. So that's really what I'm interested in.
Yeah, so we work, when we work with the more deprived communities, we always work with our voluntary sector partners and third sector partners. So we've already, my team have got really good relationships across South Yorkshire, so we've already started to put some feelers out to ask what groups are meeting over the next 5 weeks and potentially beyond that, to see who we can go out and talk to, because we know that we need to go and see people and really get some face-to-face feedback from people on such an emotive issue.
Just to give some context, I think I may have raised it previously when I've been here. When we talk about deprivation nationally, actually in South Yorkshire we're talking about 40% of our population. So actually a large number of our communities are by definition deprived. So I wouldn't want you thinking that there are sort of small groups. We've got quite a big challenge in regards to, you know, index of multiple deprivation and how that, you know, pans out across South Yorkshire.
Just one issue. I know in my area, and I can only speak for my area, that the voluntary sector organisation you might use doesn't close down for the summer, but it is a lot of people that their activities are really cut down and staff are on holiday. So you know, it's quite a big chunk of work you're asking them to do. So I don't know how you're going to do it in such a small time frame. In such a small time frame anyway, because I think it's 5 weeks is not long enough at all for this kind of engagement. So again, can you just address that problem?
I think we're preempted. That might be something you put back to us, so that's not a surprise to hear that.
No, it's not. And I think the other point, just to add to what Katie said in terms of how we are engaging with the communities, we'll go out with, you know, experts and, you know, people who will be able to sort of explain why, also, you know, be, you know, able to have those conversations, you know, within the communities and sort of, you know, very much listening to what individuals have got to say. There's something to me about really, you know, IVF is really emotive, isn't it? So it depends very much as well on who you speak to, because if you speak to individuals who it may not interest, or it may not be something that they're too you know, too worried about, you can obviously get a different view. And so it's really important that we've got a really good mix of communities and individuals across South Yorkshire to make sure that's a balanced view.
So you're just taking account of the fact that people are on holiday in these organisations, but would be asked to do that work. Okay.
Councillor Keeder.
Thank you, Chair. I was quite interested in a point of clarification when you were answering the councillor from Doncaster. Is it Councillor Knight? Yeah. You said that you were going to consult women of the reproductive age. I'm a mother of a daughter who is about to have to embark upon this traumatic experience. And I would like to think her husband might be, and other young males that are affected in this way, I mean, would be consulted as well. So I'm just quite interested in seeing that might be a part of that. And the other question is, I've got a few, but I'll only ask two at this point. Obviously, people are not interested until it happens to them. And you don't know, it could happen to anyone's sons and daughters here, and it's incredibly traumatic. I was interested in the percentages. The percentages were all well and good, and they're nice to have those numbers there. But how many people do you think this is going to affect? I'd like to have a number across the South Yorkshire. Just those two questions. Thank you.
If I just take the first one, you're absolutely right to pick me up on a point of clarification there. You're right. The legislation says we need to involve people who are directly affected and their family members. So we will absolutely be involving family members and grandmas as well as husbands and carers.
Granddads.
And granddads, sorry. Yes. And anybody else.
This brings me to my thoughts and our thoughts, and we think that the 5-week timescale is not sufficient and it's got to be extended considerably. We will have people who've had the lived experience, and you'll have records of that, and I think that we need to be asking them, because I agree with you, if you haven't been part of it, you'll not understand how traumatic it might be. But the people who've got the lived experience would. But we've also got people who've lost children during a natural cycle, who again would be part of any consultation, because again that's another form of trauma in terms of bringing life into this world. So that's why I think we've got to be more careful. Now, I can only speak for Barnsley in terms of our reach as a local authority into community groups and organisations, which is quite significant, because of our new way of working with area councils and ward alliances. And so I think if we work more closely with local authorities, of all 4 local authorities, does this impact? It doesn't impact on yourselves. This is just South Yorkshire. So to work with 4 South Yorkshire authorities, because I'm sure, and Health Watch in particular, in those authorities, I think that would be a better reach, so we can get better conclusions. And instead of trying to run timescales to next meetings, we need to be extending that further. And I think a gold standard of a decision this significant needs to be evidenced as part of the decision-making process for people when being consulted, when they see the results, because there would be a reaction, I'm sure, because everybody will have a view, as we all know. So what I'm trying to establish, if you agree with me, is if we've got that gold standard all the way through, whatever decisions made at the end, you can justify that decision through consultation. And to make it a question, do you agree with me?
I do agree with you, yeah, absolutely. And I think you've made some really good points about making sure that our involvement reports bring some of that lived experience to the people who'll be making the decision as well, because it's not just about facts and figures and numbers and views, is it? It's about how that impacts on people's lives. So we'll take that into account and make sure we bring that into the engagement exercise as well.
Oh, the numbers, sorry.
We're just working through the numbers at the moment because we have to look at kind of contract activity and all that. So when we come back, we'll definitely be able to share with you how many individuals this is affecting.
Councillor Keenan has indicated she's happy with that. Have you got something to say, David?
Well, I was just going to say we thought the baseline figures were 200 and we're talking about 20 to 30% going through a second cycle. So that gives you a rough guide of kind of the impact, but we can clarify that. I just wanted to bring in and said that since the papers for this committee were published publicly, you'll have seen there has been some media interest already, and there's some people been expressing some views. So we know, Health Watch Doncaster have, they've shared some of their views about the length of consultation. So when I said to you, we weren't surprised at some of the things you might share because we'd already, seen what comments had already been on media.
Okay, thank you for that. If there's no more questions, thank you very much for your input. I'll move on to our next item, item 10.
So just while Leslie's coming up to the table, so I think, picking up our previous conversation about the timing and bringing something back, I guess we didn't really acknowledge that if we were going to do some consultation work on gluten and we were going to do it on this, it would seem timely that if there was an opportunity to bring both of those back, then we'd look for a date, try and work with you to look for a date to bring both things as a future agenda item potentially.
Yeah, I think we'll make that work. We'll make that work. Thank you. Welcome, Leslie. We've got our update on the non-emergency patient transport. Well, so I'll go back to recommendations from previous one because I've got a script. We acknowledge contents of the report and we'll provide feedback. So I think the adoption update has been changed. So yeah, we know what we're doing. Thank you. Well, they know what we're doing, I might not. So thank you very much.
So as you already referenced, actually the last meeting in October, I came, Leslie, and we had colleagues from Yorkshire Ambulance Service as well. So what's happened since that time is the board did consider this and approved for us to proceed with the intention to move to a national eligibility criteria for South Yorkshire. So that went live, and that new criteria's been in place since the 1st of April 2025. Since that time, West Yorkshire also went live on the 28th of April, and Humber and North Yorkshire are now live. They went live on the 27th of May. So across the Yorkshire and Humber footprint, we've all moved to this new criteria. There were a number of points that were raised at the last meeting, and Leslie's going to help me and respond to those and tell you where we are at this present time.
Thank you. My name's Leslie Carver and I am the Urgent and Emergency Care Programme Manager for the ICB. So it's good to be back to be able to give you an update. As David said, we went live in South Yorkshire on the 1st of April. So we do only have a few months worth of data and information to be able to share with you. Since it was implemented on the 1st of April, we've had 17 official complaints that have come through, received by the ICB, and 15 of those were upheld. I'll go through and just give you a little bit more information about how the escalations happen. What we're finding is we've got some emerging themes as we went live on the 1st of April. So some of the themes that are coming out that we are taking into consideration as an ICB is looking at cancer patients and whether patients should automatically be accepted for transport when they are attending their appointments, when it's directly related to cancer care. And that would be similar to what we have in place for renal patients at the moment. Whether there should be an option for a clinical override as well, whether clinicians' explicit assessment that a patient requires transport should override the standard eligibility criteria. Short notice exceptions as well, whether short notice approval should be permitted for patients previously eligible for transport. Renal patients outside dialysis, what we are finding is that renal patients do still receive transport, and they receive that 3 times a week. If a renal patient has got an appointment which is non-renal related, should that patient still receive that PTS? And also travel cost concerns as well. So we've had significant concerns about affordability of alternative transport options. So what we are doing is we're looking at that on a regional footprint. So we're working really closely with West Yorkshire and Humber North Yorkshire as well to see and look at those considerations. With regards to YAS, they've been working with their business intelligence team to provide some data for us. And you can see as you go down, which is on page 3, that we've seen a 55%, just over 55% reduction in saloon cars booking year to date. So that's from the 1st of April. And W1 bookings, which are wheelchair bookings, have seen a lower rate of reductions of 12.3%. The reductions of those combined is equating to 6,800 bookings. That's not individuals, that's actually bookings. The data above does include Bassett Law data. However, as Bassett Law comes under Nottinghamshire ICB, it was not possible to separate out the geography and information any further, unfortunately. And I know that was one of the questions that we did get asked. So some of the reflections from our Yorkshire Ambulance Service colleagues since the implementation is that they've looked at their internal communication. So the initial messaging about the changes did not reach all the acute staff involved in the booking process. So that did lead to some confusion and concern at the beginning. So further communications have since been issued with operational staff encouraged to cascade those key messages. The booking system adjustments, there's been some minor revisions made to the wording of the questions and improvements in the implementation with the booking system as well. Complaint response time. So complaints have remained low, but steps have been taken to improve the timeliness of the responses to the ICB so that we can pick up any complaints that are coming through to us. What we've also looked at is the DNA rates. So the do not attend rates for patients in the top 3 categories of individuals that have not been accepted for PTS. So that's the oncology service, ophthalmology, so the eye service, and the diabetes service as well. And you can see below, we've looked at March 25 before the criteria came into place, and then we've also looked at after the criteria went in place, so from the 1st of April to the 23rd of June. Looking at the information and working with our BI colleagues as well, we haven't seen anything, no changes in the data that are statistically different in terms of the data trends. So there's nothing that we can actually pull out to say we've seen a significant reduction in people attending ophthalmology appointments or a significant reduction in the diabetes service. However, it's only from the 1st of April until mid-June, so this is something that we're going to monitor on a monthly basis so that we can pick up on any trends and put something in place if needed. So the work so far, there's been provider and stakeholder briefings that were sent out prior to the 1st of April. It was limited due to the local elections, but you can see the briefings that went out in Appendix 1. Taking into consideration that people do need different forms of communication, the ICB has the accessibility tools that are available via their website, and also been working with local communities to understand what other target groups we need to focus on as well. The comms team are going to be producing a toolkit that will include news articles, social media, flyers, and that will be shared through communities through South Yorkshire and NHS providers as well. Also looking at how the information is shared, so in relation to easy reads, does it need to be visual aids as well for individuals? The appeals process is being put in place, and that's, you can see that through Appendix 2. So we've looked really, really closely about how appeals are fed through to the ICB. We've also looked at the statutory and mandatory training of the Yorkshire Ambulance Service team as well. The staff are also looking at adapting their questioning if they believe the caller is not understanding the questions. And then if individual cases are considered by the ICB, so the 17 that I told you were all the ones that were escalated to the ICB, and there were only 2 that were overridden by the ICB, and PTS was provided. We've provided alternative transfer options information, and you can see there we've got on our website, and also on there we've got information about the healthcare travel cost scheme as well. There's further work that we are doing around the healthcare travel cost scheme, because it's a bit clunky, and sometimes the cashier offices are not open. We know that people have to pay up front and then they've got to go get their money, so there's some work, an awful lot of work that we are going to be doing on that. We also know that there's a discrepancy about the mileage reimbursement rates as well, and so that can be different in different places. So it could be different in Doncaster compared to Sheffield. So that's some work that we are doing with regard to that. So we are also looking at trying to improve the way that if people do access the healthcare travel cost scheme, that everything is digital, because a lot of it is postal now. So the ICB is working with the business services and looking at getting that put in digitally. And I know that not everybody will have access to that and be able to do it. So we'll work with our local communities and voluntary and community organisations to be able to help support that as well. We've also got some information which is Appendix 3, which is looking at the numbers of people that have applied across South Yorkshire for healthcare travel cost schemes, so we can do some targeted work around communicating out as well. We also put in a funding bid, Pathfinder funding bid, where we wanted to do some further work, and you can see that in the last paragraph with regard to the healthcare travel cost scheme, and we did that in conjunction with West Yorkshire and Humber North Yorkshire. But unfortunately that funding was pulled by NHS England. There's no alternative funding available at the moment, but we are always on the lookout to see if there's an opportunity funding that we may be able to access to be able to work in collaboration with our wider West Yorkshire and Humber North Yorkshire colleagues. What I will say, and what's not in the paper, is that working really closely with West Yorkshire and Humber North Yorkshire, everything that's in this paper is what our other colleagues are doing as well. So we do have a meeting every 2 weeks to discuss if there's some themes that are coming out in other areas that we may not have thought about, if there's some work that's available that we need to look at and consider for South Yorkshire patients as well.
So just a final couple of things from me. So if you remember, it was a needs-based criteria nationally that was promoted. I think it's fair to say there's been some teething problems, but I think we've been working through those. Each of the complaints I personally review, and I put my name to those in response. And hot off the press, Yaz have communicated out to me this week to say they are committed to do a review with 3 ICBs and we have our regular meeting with them on this Friday, so it's likely to be on the agenda item there. So we welcome any comments and questions. Thank you.
Right, thank you for that. I'll move to questions. Councillor Knight.
Yeah, I think I'm the trouble causer today. David, we were looking at transport and the requirements. There's a lot of, I notice, people who have disabilities that are wheelchair bound or whatever, or have disabilities, but also have disability cars, mobility transport in other words. And something that came out a while ago was the fact that they'll still use the service, the YAS, in preference, because if they go to do an appointment at a particular, whether it be Sheffield, Doncaster, by the time they pulled up at the hospital and got out and gone into the hospital, there's a parking issue that becomes the issue. And so they become a burden upon yourselves, because they look to you and say, well, we'll use the YAS because they know that they're going to be picked up, dropped off, and they might, in all fullness of time, whatever, but it's that part that where they have the mobility cars, they have the ability to get to the hospitals, but when they get to the hospitals, again, once they've unloaded, or unloaded being in inverted commas there, obviously, but to get from where the front door is of the hospital, and then what do we do with the vehicle or whatever? And I think there's a degree of help maybe. I don't know what to suggest there. I can see that there's potential for savings by people bringing their own vehicles if the facility at the other end, when they dropped off, because it's usually two people, the carer and the mobility vehicle and the person in question. So again, they tend to lean on you a little bit, I think, sometimes when there's a bit more could be done by those people. And maybe when you're asking about what their needs are and what they have available to them, to sort of look at a little bit more closely at what they're actually, how much they're using or abusing your service that you have on offer. You do offer a marvellous service, especially for the end-of-life care. And I noticed that Firefly do an exceptional service between Doncaster and Sheffield, and they take a lot of the burden away, I know, but it's the other ones, the regular or irregular appointments, that I feel as you're being a little bit abused on, and maybe a little bit of area there to look at. Sorry to sort of raise that with you as a point of thought.
So we weren't aware of that as a theme. We can take that and have a look at that now. Now you've raised it. The Firefly and alternative transports is something we are trying to maximise and utilise. We have committed as an ICB and funded some of these ourselves. So we would want to support people who, particularly Firefly and those people going through cancer treatments. It is a fantastic service, and actually it meets their needs out with a sort of generalised patient transport service. So we are directing people and connecting both the patients and the services to be able to support each other. So that's something we have worked on. Thank you.
You've mentioned in your presentation about the remuneration for travel being a bit clunky, and what do you think it might look like, and potentially could it not be a travel pass in terms of people having a pass and the people then who do the transport claim the monies with invoice?
I mean, I guess the healthcare travel cost is a national scheme that's run. There's some local variation in how that's implemented. So I think it's recognised nationally, which is why when this pilot opportunity came up, we jumped at it because we thought it needs brought into the kind of, modern world of how people utilise services and how they get reimbursement. So that's why we were so keen for that. I think it got tied up in some of the other financial challenges that the NHS have at the moment, but we've expressed our interest of that, and we are doing some local work independent of that, of working with our providers to make that as smooth as possible.
Yeah, also West Yorkshire Association of Acute Trusts are piloting a scheme and to issue NHS prepaid bus passes. So we're watching that with, we're just waiting for the evaluation to come through on that, and we've got a meeting next Tuesday, so that's on the agenda. So we'll be able to have a look at that and see whether that's something we want to consider for South Yorkshire patients.
Actually, there's having 3 items on the agenda at next meeting. We're going to organise, we get feedback. Just on that, in other meetings I've been to, we make up at, we've discussed community transport, and we've got different levels of positivity in community transport in all our 4 areas. Is there a possibility of linking in with community transport to support people in instead of ambulance service to save costs?
So certainly the consultation that was undertaken by the Mayoral Combined Authority we did input into, and we were conscious that when we brought it last time that was happening. So that's more on the provision there. Leslie, I don't know about the other community element.
Yeah, so we are linked into the alternative providers for community transport. I think what we're trying to be mindful of is that if there's an increase in community transport, how does that community transport provider be able to provide that service if potentially there's no additional funding for that? So we're working really closely. Our contract manager, Carl, is on having weekly conversations with the community providers to be able to keep an eye out on the numbers that are coming through. But we've got some fantastic community providers across South Yorkshire, and they are really supporting the move with regard to patients being able to get to their appointments if they can't access the PTS service.
Thank you for that. Is there any more questions? Simon, right.
No, call me Simon, it's fine. My mother does. Obviously, we were coming to August. When will we be able to say how many people have been denied transport under the new criteria?
We should potentially get that next week. Yes. So we were waiting for Yaz working with the BI teams, but unfortunately, because we have to have the paper in a month before, we couldn't get the data for this meeting. But hopefully, for if you would like to invite us back, we would be able to provide that information.
Thank you. On the did not attend data, can we clarify if Bassett Law is included in the Doncaster numbers? The comparisons from March to April 25, May to June 25, these are best weather months. Surely we should compare similar year periods.
So they are included, that's the first thing to say, and I think as we referenced earlier, we continue to monitor that because obviously we're conscious of the short period of time that we're reporting back to you at the moment.
Okay. Point, I think one of the fellow people commented on the pilot run by West Yorkshire Association Trust concludes March 25. Surely we should be able to say if the prepaid bus tickets is an effective way to address the issue.
Yeah, it didn't complete in March 25. It was Yeah, it was supposed to, and we were waiting for the information to come through, but it got delayed, and I think it was due to funding and just the implementation of it. So I'm in contact with my counterpart over in West Yorkshire, and as I say, it's on the agenda next Tuesday, so hopefully we'll be able to get some more information then.
Okay, thank you. One final question. Just looking through here, there's in the YAS staff undertake statutory and mandatory training in the following. In the Oliver McGowan Learning Disabilities and Autism Awareness, do they practice sort of Makaton sign language, or is there visual aids to help people with learning disabilities to explain the journey?
There are visual aids, but I'm not sure about the other, but that's something I can definitely find out.
It's something that, having a disabled son at 31, I've experienced that a lot of transport, it's very important that they have that training and understanding of it.
Yeah.
So I'd appreciate if you could look into that and get back to us.
I mean, as a Commissioner of the Service, we believe that should be standard
It should
as part
be
of the disability.
Unfortunately, it shouldn't be standard, but on the front line and in the trenches, it isn't, I'm afraid.
So we can ask that. I think just to go back to your previous question about when we look at the numbers of potentially people that were declined. I think we need to look at that in the context of all the people, the journeys that are supported, because I think it might just give a little bit of a kind of a, you know, focus into one area of,
Okay.
you know, there are thousands and thousands of people who are supported across, you know, Yorkshire and Humber every day. So, you know, I just wanted to put in context is the number that, you know, we consider may be relatively small in comparison, but, you know, equally we want to ensure that people do get to appointments, that we utilise our health services for minimising unnecessary travel. I think that's what came up, maybe yourself, Councillor Stowe, last time, sort of saying that we're making the most of, you know, digital consultations and other mechanisms where people aren't taking, you know, aren't having to travel to a hospital unnecessarily.
Okay, thank you. That's all, thank you.
Potential equipment for people to be able to access that, or, as we said in last meeting, travel to their nearest hospital where there could be a room where they can do it and supported by family, and that'll save travel and everything else. Now, I've got a question just in terms of non-attenders. Have we got the data, and are we in a position now to see if there's a pattern of non-attenders geographically, and then ask the question, why are they not coming from that particular area?
It's probably a slightly different question from what we've answered. What we've answered is the impact of introducing this criteria. Have we seen an increase in DNAs? That's not the case. I think what you're asking is a broader question as of the people who DNA. Do we have an idea of where geographically they come from? Have I heard you right?
Yes. For example, we get from Barnsley. I don't know Barnsley. From people in Durn to get to Sheffield hospitals, it's a train travel or it's 2 bus travel, or people from Royston. So my question would be, is there any particular place where people are not coming from because it might be impacted on travel restrictions? And then we need to have a solution if that ends up being a geographical problem. That's what I was basing that question on.
I think it was probably out of scope of what we were considering specifically for this, but it's something we can definitely give some consideration to.
Is there any more questions? Councillor Keenan.
Thank you, Chair. It's only a really small one here, but what measures are in place to evaluate the effectiveness of this new criteria, and also to make adjustments if it's necessary?
So I think I've said the commitment with the YAS to review this, because the number of the reduction in the number of people who travelled by the specific non-emergency PTS elements that this was going to impact were greater. And I think there's the national criteria, and I think we want to re-look at that and say, are we capturing the needs of our local population? And I mean that across the 3 ICBs. So as I say, that commitment, we've had that commitment this week, and as I said, that'll be picked up as a starting conversation on Friday. So I think we continue to review the service. I don't think we're fully saying, right, it's been bedded, move on to the next thing. I think we have got other items that we are looking at, but I think we're still in the early implementation phase of this, so we're quite mindful of continuing to monitor that and learn as we go along.
Thank you for that. I've no indication of any more questions, so thank you very much. And I'm sure this subject will be coming back very soon, and we'd welcome that. So if you can liaise with Emily, if we've got decisions that are coming through in period and possibly at next meeting, might be an opportunity. So thank you very much, and thank you very much for your input today. It's been cracking. Thank you. Right, we'll move on to item 11, the work programme, and this is you, Emily. You can stay if you're still riveted, you know, if you... Oh, I'm sure. My apologies for running over.
Okay, thanks, Chair. I think given the discussions we've had today on gluten-free prescribing and IVF, I think it seems like the easiest course of action would be for me to go away and liaise with Katie and with support officers from all authorities to work out a schedule and a reasonable timescale for those things coming back, and trying to find a date that can suit most people. I think we'll struggle to do it today. And along with that, review the content of the work programme in terms of the next couple of meetings to see what we can consolidate to try and be as efficient as possible in terms of the number of meetings that we hold. It's been brought to my attention that there are a couple of outstanding actions on here regarding thrombectomies and the Mextra Centre, which we'll chase up. And then there's an opportunity for anyone to flag anything else that needs to be on the work programme going forward.
I'll open that out if anybody's got any thoughts or what needs to go on work programme, or could it be, Emily, people go away and have a think about it and email you? Yeah? Is that okay? So that brings us to the last item, date at next meeting, which I know we're going to organise. So thank you very much for your attendance today. I've enjoyed that. Marks out of 10, you've got 10.
Yeah.
Thank you.